Imews. So what's new about Imews? So Imews basically is the recording of the vital signs of anybody who is confirmed with pregnancy and up until 42 days after their childbirth. So when we look at the history of Imews, it was initially introduced in the UK in the 1990s, and then it gained its momentum here after a sensitive case in Ireland. And then the College of Physicians in Ireland took it, and then it was formulated in 2013 in an Irish perspective. And since 2014, it's been rolled out to the clinical areas, and Beaumont has been doing it since 2014 from its first rollout in Ireland. There are variations based on the need of the particular place, as in it can be a modified obstetric early warning score. If it's in a pediatric population, it can be a pediatric early warning score. So there are variations to these. So then when we look at the need for it in Ireland, why? Because of the mortality and morbidity among the pregnant women that are admitted to the hospitals. How is it making an impact? So when we look at the maternal deaths, they are either due to direct causes, which means the deaths are from the reasons that are related to pregnancy-related issues, such as it can be a venous thromboembolism, it can be a PE, preeclampsia, early pregnancy deaths, or it can be psychosis that is related to pregnancy or postnatal period. Indirect maternal deaths are deaths that occur in a pregnant woman due to other mortality and other comorbid conditions, as in like it can be cardiac deaths or other indirect deaths or neurological causes. So what do we see about the trend is there are direct maternal deaths and the indirect maternal deaths are consistently growing, and particularly the indirect maternal deaths have grown exponentially. And when we look at the morbidity among pregnant women, this is about women admitted to HDU and ICU setup. You can see since the introduction of the Imews that it has significantly reduced. So the data collected between 2011 and 2015, there were 1612 patients admitted to HDU and ICU. Since the introduction of Imews in 2016, it had reduced to 406. So are these early warning scores working? They're definitely working. So the maternal mortality rate in Ireland was 6.5 by 100,000 maternities between 2013 and 2015. And the severe maternal morbidities was 6.4 per 1,000 maternities. So looking at various studies across the world, the Imews or the early warning scores adapted to the particular country are definitely working, and it has significantly reduced the maternal morbidity by 7.2%. So when we look at the recommendations, so the last recommendation was made in 2019. It's made every 5 years. So we'll have the next one published in 2024 and out to the clinical areas by 25. So the last recommendations currently that we are following are from February 2019. So what do they say? Imews should be a complement to the clinical care, but it should not replace the clinical judgment. And if the mother or her relatives, if they have a concern, they have to be taken seriously because they know them better. And vital signs recording, when it comes to maternal perspective, it's done once on admission and it is continued as needed. And in the antenatal period, at least once in 12 hours, we need a vital signs check done. And in the postnatal period, we need once every 12 hours, and at least once a day, we need one recording. So how do we then communicate the findings? And if we have to escalate, then it is ISBAR. So ISBAR in emergency and ISBAR 3 when it comes to non-emergency conditions. And how do we escalate? We escalate using the escalation protocol. And the technique needs to be in par with the guidelines. And how do we know that the techniques are working is having a local governance group who are evaluating. And let us see what is happening locally. So how are we performing locally at Beaumont? So our A&P, Karen McGowan, she did a study or audit. So we have done an audit in 2015 and a re-audit was done in 2022 to 2023 period. So between 2022 and 2023, there were 20 patients, maternity patients admitted to Beaumont. So 14 out of the 20 charts were pulled. So among them, one was transferred to Rotunda for further observations. The rest were all discharged from here without any untoward consequences, and there were no adverse outcomes of the maternity patients admitted to Beaumont during the study period. But when it comes to documentation, how are we doing? We are doing good in certain areas, but there are other areas that needs improved. So as you see, we're doing good when we do them and record them, but we are not doing great when it comes to urine output and pain score. And when we see about the escalation, we certainly aren't doing great. So we are not, the national standard is to have 80% documentation, and we haven't achieved that. So what have we achieved? So we have achieved well, and as I said, doing them, recording them, initialing them, but in escalating them and doing the urine output, we need certainly to be improved a good deal about them. And then we need to start using the ISBAR tool more. So what is the difference between the normal early warning score system and the Irish maternity early warning score system? So we are giving some leeway for the physiological changes that happens in a pregnant woman. So as in the respiratory rate, it's slightly less in comparison to the adults, the normal adults. And there is again leeway for the heart rate when it comes to the pregnant woman. And the blood pressure, we take it very serious when it comes to a pregnant woman because of the risk of the eclampsia and preeclampsia. So when you look at the parameters for the respiratory rate in a pregnant woman, the target is 11 to 19 breaths per minute and SpO2 about 96. And then for temperature, we are very tight. So it's between 36 and 37.4 and not like a general adult where it is 36.1 to 38. And the blood pressure, as I said, we have very tight with the parameters because of the risk of the preeclampsia and eclampsia. And heart rate, there's a slight leeway between 60 and 99. So how and when to escalate? So the triggers when it comes to a pregnant woman in regarding to their vital signs, they are marked as yellow triggers and pink triggers. So if there is one yellow trigger, then we repeat the full set of OBS after 30 minutes and before 60 minutes. And if there are two yellow triggers or one pink trigger, then we call for the obstetrician to review them. If there's more than two yellows or two pinks, then we take it really seriously and call the obstetrician for immediate review. And how do we escalate? In an emergency situation, we use the ISBAR tool. And in a normal situation, we use a ISBAR 3. What does the ISBAR 3 mean? We give more leeway for the person who's attending the place, as in if they're locum, if they have, we take their background and everything, and how are they adapted to the area. So that's the difference between ISBAR and ISBAR 3. So when it comes to sepsis, and we say sepsis 6 for an adult. For a pregnant woman, the trigger is 6 plus 1 because there is a baby in the womb. So the trigger is 6 plus 1. So what are the take-home messages? Imews is used to complement the clinical care. It's not to replace the clinical judgment. If the woman or her visitors express a concern, please take it seriously. And how are we going to get help? Escalation is the key using ISBAR or ISBAR 3. And compliance with the national guidelines, we are doing great in doing the vital signs and recording them, just not for the urine output, and a bit more to be done for the pain scores. But when it comes to escalation, we need to work really hard to be in compliance with the national guidelines. So to know more about these, you can look at the Irish Maternity Early Warning Score system, and then you can look at the HSE land, where there is more about Imews and sepsis management of adult, including the maternity woman. Thank you.